in which case may we then move into 2014-15, the commissioning round update?
So I think, again, Malcolm, two parts to this. Going to ask Barbara to give an update on where the specialised and the CCG commissioning process got to. Paul, on the money. I think the fact is that a lot of the good work that was described in 13-14, those pressures we either inherit or have intensified into 14-15. The reality is, if NHS spending is basically flat in real terms, if we see spending on high-end tertiary care going up by 5 or 6%, that means cuts elsewhere. And that has been preempting the investments that we want to make in primary services, community health services, mental health services, other parts of the environment. We've had to obviously build a part of the, in fact all of the 13-14 specialised overspend into the run rate going into 14-15. But it is absolutely crucial, and we've got a very substantial work programme underway now to ensure that we do not have a repeat of this level of spending preemption on specialised as we go into 15-16. And in order to do that, as I said in my written report, Paul Watson is leading a piece of work urgently over the next 3 months to put in place appropriate controls there. We're going to have to look at the extent to which the specialist commissioning definition was extended in a very expansive, over-expansive way, in my view, going into 13-14. We're going to have to find new ways of getting CCGs to work with us on some of this so that we have that population-based set of shared judgments around trade-offs and a variety of other things as well, which we will talk about in future. But that's the context in which the commissioning round is occurring, in addition to the pressures that both Barbara and I have talked about that we need to sort around elective care and the Better Care Fund and so on. So, Barbara, do you want to give a State of the Union?
Thank you, yes, and I think this is another comment following on Moira's comment. This report is sort of the tip of the iceberg, given the huge amount of work that is going on across the NHS at the moment to do the planning and contracting round. That's work in our own area teams for their direct commissioning functions, in CCGs as commissioners, but working obviously with the teams in providers to make sure that the plans we have in place are right, deliver the right services for patients, but also deliver value for money for the taxpayer. And I think what I will mainly do is focus on 14-15. We have talked about a longer term view and how through, as Simon has said, through to the autumn we'll be looking at the strategic plans in order to put ourselves in a sustainable position for the future. But for 14-15 we need to look at the aspects of the planning and contracting round which make sure that we get the right services and can balance the books. And an enormous amount of work has been going on. It's a joint piece of work between operations, commissioning operations, and the directors of finance, all the way through NHS England system and through the CCGs. And we are making really good progress in what is an extremely complex environment. If I can remind everybody how the planning process works. The contracts which are signed between commissioners and providers are key to ensuring that providers can plan for the volume of activity that they need to deliver for our patients. They're key for commissioners because we can look at all the different elements of activity that's needed, either urgent care with the ambulance services to deliver the IAPT services that we want to see, the full range of elective care. That's often one of the biggest issues that is discussed in the planning round is are we as commissioners commissioning the right volumes of elective care that our providers can then put their plans in place. But in the final analysis, I do think it's important to remember that we have a payment by results system, and particularly for elective care. Whilst these plans are fundamental and important, and any deviation from the plans that have been agreed by commissioners and providers will result in conversations as the year goes on, providers are absolutely entitled and will charge commissioners for every episode of elective activity under payment by results that they need to undertake to deliver services for patients in line with the standards that have been set. And therefore the planning round is really important, but there is still considerable risk as you go through the year if activity rises. And in terms of context, I think it's important to remember that the CCGs across England are in the process of trying to agree 393 contracts with our providers. providers, and our specialised commissioners in area teams are attempting to agree 291 contracts with providers. So that's an awful lot of contracts to come together to give us the national position that we want to see. We are making good progress. It's always iterative, so at any point in time, every day that goes by at the moment, more contracts are agreed with providers, more plans are put in place where people say, yes, you know, that's the level that we can agree is necessary. Since the writing of the board paper on the contract tracker, and apologies, there is an error. I don't know whether anyone spotted it in section 7, and because Midlands and East CCGs, there are only 3 of them with contracts not signed, which makes the national position 5 at the point in time on the 8th of May. Which I think you can see is a very small number of contracts that have gone to arbitration compared to the very significant numbers of contracts we have. Since that time, more and more that are in the column contracts not signed and not agreed have become agreed. And it is our expectation that the number of contracts going to arbitration from CCGs will increase by 1 or 2 only. So again, I think the recognition that out of all those contracts that we may only have a handful, we will only have a handful that are going to arbitration from CCG is really important. We do need now, however, to ensure that at a national level that the contracts that have been put in place will deliver all the things that we have committed to deliver through in the mandate. That delivery for us is largely many of the things in the mandate delivered through CCGs. We ask them for their plans. In many cases, we find the CCG plans very ambitious and going further than we could have expected, which is great for patients. In some areas, we need to challenge that ambition because we think that it's not right for patients or doesn't support what we need support to deliver our commitment for the nation as a whole. So we're going around that loop again, and we will very much be focusing on mental health, making sure that the right services, that's getting the right focus, particularly on IAPT and dementia. We will, of course, be focusing on the elective activity because of what we've talked about a few moments ago about our concerns about the 18-week referral to treatment standard that we need to meet. And not only is getting that activity right vitally important for those services for patients, it's vitally important for us because if that volume of activity doesn't prove to be correct, then we run into financial problems as the year goes on. So we're working very closely with our CCGs to make sure that what they are commissioning is realistic. There isn't one size fits all. All the local health economies have entirely different circumstances, which means that it's without that local knowledge, you can't really assess whether the amount of activity commissioned is broadly in line with what you expected, and that's what all our area teams are doing. In terms of specialised commissioning, we've made a very significant amount of progress over the last few weeks. It is an enormously challenging area, and I won't reiterate the reasons why specialised commissioning has been even more challenging for NHS England since we came into being. But it will continue to be challenging because inevitably these are the patients who need very seriously ill and need very complex treatments. But just to reiterate what's already been said, if all of us, and we all have the ambition to support patients not to become ill in the first place or to keep them well in the first place, we absolutely need to make sure that what's going on in specialised isn't compromising our ability to do what we need to do. I can report that since the addition of the reserves that have been put into specialised commissioning for this year, we've given the area teams the ability to use reserves to go through the planning round with providers, that for the most part we have agreement with providers across all of England on specialised commissioning, and that is within the allocation that the commissioners have been given. We will see again a small handful going to arbitration. Everyone has broadly closed the gap and can agree with their local provider that this is broadly the level of activity that we expect to see. There are a couple of notable exceptions, often very large hospitals in London who have a high degree of high volume of specialised activity, and that the sort of resolution of those contracts is really holding up everything because it's often holding up the CCG contracts as well. But I do think we have a duty in NHS England to make sure that these contracts are pulled together in a way that doesn't compromise those populations, because it's the same population that will require specialised services and secondary health care and primary care care and preventative services. So we're still continuing to work with one or two of those hospitals to try and come to an agreement as to how we can manage that budget in a way, and the planning of those services in a way that doesn't compromise other important things that we need to see. And we're optimistic that over the next week or so, for the most part, that will all be resolved. That doesn't, again, in any shape or form, underestimate the risk. I think there are risks in the CCG contracts, as I've discussed, particularly in terms of activity, because in a number of the contracts there is an ambition, the right ambition, to support patients not necessarily to be admitted and to have alternative treatments. If that doesn't come off because of the nature of PBR, then that puts the CCGs at risk. I think there is an even much greater degree of risk in the specialised commissioning contracts because of the activity levels that have been agreed with providers. But as Simon says, since April the 1st, we've been allowed to make a huge increase in the capacity we have nationally to oversee the specialised commissioning budgets. And I would really like to commend Paul and the turnaround team and all the others in all the other bits of NHS England, and particularly out of the area teams doing the contracting, who have got us into a place whereby we can get through the planning round, close the contracts and move forward into treating patients in a way that makes sure that we get the best value for the money that we've got.
Difficult to add much to that, so I probably won't, except to say that the shape of the numbers that emerges from that, if you remember back to the allocations paper, we had a very clear strategy about how the drawdown in 14-15 and 15-16 was to be deployed. We've got 400 million of drawdown, which is just surplus from previous years, applied in year to financial needs of one sort or another. In 14-15 we said priority would be given to specialised commissioning. From all the discussion this morning, that it's clear why that's necessary. That's the reserve that Barbara was talking about that we've now allocated to the relevant area teams. The consequence of that is, of course, that every other part of the system needs to work within the allocation for the year. We are very close now to getting the plans themselves to balance to that expectation. We're about 200 million off in total as of the end of last week, roughly half and half CCGs and direct commissioning. Reminder, 200 million sounds a lot of money. It's a fraction of a percentage of the resource that we've got. On the CCG front, clearly the challenge is to make sure that the aggregate, all the CCGs added together, do not have a drawdown. That doesn't have to mean that every single one can't have a drawdown. It means the totality can't. We're about 100 million short of that at the moment. We're working very intensively and positively with the Commissioning Assembly Working Group for Finance, with whom we did the work on the allocations and the planning process last year, and we've now brought together to tackle the rather more immediate challenges, and indeed we'll continue that as the year goes by, because I think the need will arise. So we're working with them on this issue of getting the CCG drawdown to a neutral position, ideally by people adopting a strategy of essentially saving their drawdown for the years it was planned to come in future years rather than this year. I'll report again on progress with that in the near future. On the direct commissioning side, we're very close, I think, to being ready on primary care in terms of being in balance in total over that, having absorbed some quite specific pressures in primary care. The big challenge, of course, is specialised commissioning, but I think enough has been said about that. And the biggest challenge, of course, is not getting the plans down to zero, which I'm confident we will do in the next few days. The big challenge is then de-risking the discontinuity there needs to be between the trends of the past and where that takes us to for the future.
Well, thank you, Paul and Barbara. I mean, it's going to be an extremely difficult year, and the year after, possibly even worse. I think we all commend the work that's been done to ensure that the contracts are in place and the planning is in place, and that we're conscious of the way in which activity can continue to drive cost through the system. And I know that the board will wish to have regular updates on how we're managing the risk, particularly, of course, of specialised commissioning in light of what both Simon and Barbara have spoken to us about this morning. Can I invite further comments from members of the board? Kieran.
Just on the risk thing, and maybe it's picking up on your comment, Malcolm, on it's depressing enough if you take a 1 year view. If you take a 3 or a 4 year or a 5 year view, it's all cumulative, and it's not only the financial risk. For me, this is existential in the sense of if we want the long-term sustainable NHS with more investment in primary care, community and mental health, as Simon was describing, there are an awful lot of things that have to come right. So we have to control specialised commissioning. All the CCGs have to, on average, balance. And it's just whether we feel there's enough IQ and capacity in the system to do the thinking to make some of the changes so that the strategy bit of this around the 6 characteristics, we do enough of that to keep people out of hospital, to help people get out of hospital and linking into social care. And it's whether the strategy bit is in place as well as the controlling specialised commissioning. And it gets back to this pooling budget and having to get that right in an awful lot of places very quickly if all of this is going to work.
Yes, so I agree with that analysis completely. I think what we've got to avoid is a false choice between assuming that 211 micro strategies can somehow sort this out, or to the extent there is risk in that, assuming that therefore just one big single approach across the country. So what we're attempting to do now on the back of the work that has been done by CCGs and that's supposed to be complete by June 20th for their 5-year plans, by hospitals supposed to be complete by the June 30th for their 5-year plans, then taking a look at that and pivoting to a different kind of strategy process that will bring together some of the national work together with the particular local circumstances that exist in different health communities around the country to say, in this particular geography, what is it you'd have to do in order to put yourself on a sustainable footing? How do we ensure that many of the new ways of working, the important things that we were talking about in terms of giving more power to patients, more support for communities themselves, actually are driving a lot of that change in that conversation. So huge effort required on that. And the truth is that I suspect the answer will be that it's not going to be some kind of neat circle that can readily be squared when you add it all up across the country for 5 years out. So that's the conversation we're going to be having to have on the back of this when we've done the work with the British people, or people of England, I should say, about what the health service is going to need to look like under alternative scenarios come the autumn. That said, let's also remind ourselves that we are in year 5 of the most sustained funding squeeze the National Health Service has had since 1948, and it's a huge tribute, as everybody has said, to the staff of the health service that, in fact, the quality of care remains incredibly high in the vast majority of cases, and that is in large part thanks to the effort and the goodwill and personal sacrifice of the 1,300,000, 1,400,000 people who are working for us. So a lot to be proud of in terms of where the NHS has got to, but as you say, Kieran, an awful lot at stake. In fact, as I said on my first day, the stakes have never been higher for the National Health Service than they are now over the next 5 years.
Well, thank you. On that sobering note, may we turn to the next paper, which is the Board Assurance Framework for next year and for the 2013-14 BAF also. Do you want to introduce this, Sam?
Yes, well, I realise this is building on a lot of work that has been done during the course of the last year to bring a real forensic discipline to thinking about the shape of risk and, more importantly, what to then do about them across the organisation. So I think there's been a lot of external support for the approach that has been taken, and Ed, I know, has been instrumental in driving this and provides that external perspective to it, so I may want to speak as well. I think what we're doing here now is a refresh for 2014-15. I think many of the risks are, well, all of the principal risks are appropriately listed here. We're going to be wanting to make sure we've properly kicked the tyres on how they are calibrated, both unremediated and remediated, and also how they're clustered, because some of these are broad environmental risks that every industrialised country is facing, such as the hopefully low possibility but potentially very significant impact were it to occur of pandemic flu on the one hand, through to pressures that exist in the National Health Service for which the commissioning system has responsibility, through to some specific programmes that we at NHS England need to get right, for example handling public inquiries and complaints, or the work that we do around supporting CCGs with their out-of-hours 111 services and so on. So I think we can categorise and cluster in order to manage. But this, I think, Ed represents a pretty coherent way of thinking about the shape of risk from what you've said.
Yes, it does, and I think several points. One, we have been from the start transparent about this, and it's great that this is out there as our approach to risk. It's shared with DH. DH only yesterday took a note which recognised the way in which we approached risk management through the board assurance framework. Our internal auditors, Deloitte, who are very rigorous and very independent, challenging, have commended our approach to risk management in their internal audit opinion and the way in which we have approached it. The chart I like best is the diagram that takes you having identified gross risk, which is a management process and a discussion process, and one which is in train, but then shows you the mitigating actions that you are taking to bring that risk down. And it's that process, that management process of discussing gross risk, discussing mitigation, and then tracking that the mitigation actions are having effect, that is the real power behind this. It's not, the concept of risk management, but it's the management processes that are taken from it. And I think we take this extraordinarily seriously. We apply a lot of effort to it. But Simon, I commend you to take it forward in this way of continued refinement for the future. It's not as dry as it looks, I have to say, and I know that may reflect on me being a bit of a sad person, but actually it's an incredibly powerful management tool.
Yes.
So thank you for that. I present this paper on behalf of the Risk Management Committee, which I chair at executive level, and I think for today it is work in progress. I think we have come a long way. There's more to do on the particular issues. It is so critical, it seems to me, that this document identifies clearly and plainly for the board what are the biggest risks, the mitigations we've got in place, that the board can take assurance on those and challenge or take action when those assurances they don't feel they're adequate. But given that it's iterative process, it feels to me today there are just 2 or 3 things that we need to do. Firstly, we were challenged with producing something simpler, more amenable, more user-friendly, less dry, as Ed said, and I hope all board members who haven't been as involved as the executive team do find this an easy format to use, even if we will need to do more work on the segmenting. So any comments on the format? I think it is important to note the closure and the transition of the risks from the old assurance framework, and that the board accepts that those have adequately been reflected in here, or risks that have been closed. I think that, again, it is important today we note the current higher level risks, although I would suggest that probably during the course of the board meeting and during conversations that we have, that these ones are getting significant attention, and then finally any particular steer on the next steps as we move forward to making this even better than it is now.
Being a lawyer, I normally really enjoy words and am terrified by depictions such as the chart that Ed likes, but I have to say that I really do echo Ed's point about the really helpful comparison of the gross picture to the net picture, because what it does is to build in, I think, almost a sort of forward movement and optimism. This is where we're going with our mitigating, which from the perspective of a board member who would normally receive an audit report and feel that sinking feeling in my stomach, I think this is really, really enormously helpful, and I thank all of those who've been involved in it. Thank you. It's a good piece of work. It's a good tool.
Do you want to say anything about the next phase of development?
Well, obviously just I'll be taking it over from Barbara as this falls to me, and I'll want to build on the process that we've got. I take risk incredibly seriously, and it's really important that we continue to both develop this as a management tool so that we bring the right information to you in a coherent way, but actively use it in our management processes so that we are the most important thing is we're taking the action on the risks, obviously. So I don't quite know what it will look like when it comes back, but hopefully you'll see a trajectory and a progression on this.
And with refinement along the lines of the Chief Executive.
Absolutely,
yes. Okay. Okay, thank you very much. The paper is taken and approved. May we now move on, please, to item 9, which is the board committee feedback, and we have reports from a number of committees of the board. This isn't an opportunity, obviously, to reopen the deliberations of the committee, but simply to learn for our own education what has been going on.